Welcome you to our presentation. Today we are joined by two experts in the field of patient screening and navigation, Paul Pugsley of Priority Consult, creator of Oncology OnTrack, and Kathy Hawkins of Mammography Reporting Systems. Before we turn things over to Kathy and Paul, I'd like to take a moment to invite you to attend our next webinar on April 3rd. On that day, Rachel Bachman, nurse navigator with Bethesda North in Cincinnati, Ohio, will be sharing her expertise on writing grants to support your navigation program. You know, in my role with Priority Consult, I have a chance to meet with hospitals and physicians to discuss best practices for coordinated programs. One of the items that we eventually get around to is the concept of trust. When you think about it, patients must trust in the quality of their physicians. Likewise, physicians are asked to trust in the ability of their navigators to track and educate their patients. And navigators must be able to trust in the tools and technologies that they select to track their patients. And not only do they have to trust in the individual systems, but oftentimes they're asked to trust in the ability of those systems to work well with one another. Today we're going to be focusing on the integration between two such systems. Mammography Reporting System, also known as MRS, is the most widely used tracking and reporting system in the world for breast-related procedures. Providing innovative software solutions since 1987, their system offers a full suite of mammography software products designed to save time, increase revenue, and improve the quality of patient care. And Oncology OnTrack, developed by Priority Consult, which is used to navigate every cancer type as well as cancer-free, high-risk patients who require special attention. Since 2009, 45 programs across the country have selected OnTrack to navigate their patients from screening to diagnosis and on through treatment and survivorship. Nearly 1/3 of those clients use both MRS and Priority Consult to complete the continuum of patient management. Our presenters today are Kathy Hawkins and Paul Pugsley. Kathy has been with MRS since December 2005. As a radiologic technologist for many years, working in hospitals and breast centers and management, Kathy brings unique insight into the clinical environment to MRS. And Paul Pugsley has overseen the expansion of Priority Consult into the oncology arena. He's focused with oncology navigation across the country and helped to create software that solves fundamental problems surrounding navigation, reporting, and survivorship. Kathy, would you like to help get us started on the benefits of your system and how it works with the Oncology OnTrack system?
Sure, Mike. I'd be glad to do that. Thanks. You know, staff appreciate automation. We like when things work and things are automatic and we don't have to intervene at any level. When both systems are utilized, there are no faxes to send, there are no phone calls to make, and there are no lost Post-it notes, which we all know happens. The information is exactly the same in OnTrack as it is in MRS. This information is relevant, it is timely, and it is accurate. It will save your staff time, it will increase staff productivity, and ultimately it will improve patient care. Paul, can you share some of the benefits that the navigators see from this integrated solution?
Sure, thanks, Kathy. The interface between MRS and Priority Consult, it's an unfair advantage for a navigator. They benefit from the upfront work done through screening and diagnosis, and it's almost like all they have to do is sit back and watch data come through, check off reminders that get created from significant procedures like mammograms resulting in a BI-RAD 045, see high-risk data come in. There's no more combing through pathology systems or hoping that the mammogram department will send a fax about yesterday's significant procedures. Really, all the upfront work happens without the navigator having to lift a finger. Kathy?
Thanks, Paul. I just want to go over this timeline that really shows the extent of the history of MRS in breast imaging and reporting. The founders of MRS included a mammographer, and they began back in 1985. The program was written and then deployed in his practice. And I just want to note that MRS is still used in that practice today. In 1987, MRS recorded their first sale. MRS became incorporated in 1990, which, by the way, was the year the BRCA gene was discovered. Congress enacted MQSA in 1992. We all saw the first edition of the BI-RADS back in 1993. Congress again was busy in 1996 when they enacted the HIPAA laws. Digital was approved by the FDA in 2000. MRS introduced the first risk stratifications into their software in 2008. MRS-7 and MRS Quest Touch was released in 2007. And now here in 2013, we do expect some more BI-RADS changes sometime this year. My point here is that over the last 25, 26 years, MRS has been involved in tracking and reporting breast imaging. And we have deployed professional staff that has subject matter expertise in its reporting, tracking, patient correspondence, statistics, and workflow. Paul?
Real briefly on the Priority Consult timeline. Priority Consult got started in the year 2000 and started working with spine patient navigation and triage. And it first developed the spine application for a physicians group in Cincinnati, Ohio. The same concepts in patient navigation were pulled from that spine product and applied in 2006 to a program in Detroit, Michigan, specific to breast patient navigation. In 2007, Priority Consult first started pioneering interfacing I'm sorry, there was a speakerphone here that was just going off. Let me unplug this phone and we'll have to back up. Thanks, Kathy. Real briefly on the Priority Consult timeline. In the year 2000, Priority Consult developed its application for spine patient navigation and triage. In 2006, those concepts for navigation for the spine patient were applied to Priority Consult's breast product, a product designed for a hospital in Detroit, Michigan. And in 2007, we started pioneering interfaces to benefit the breast patient navigator. MRS and Priority Consult began their work in 2009 to develop the full-scale interface that we have today. And in 2012 is when Priority Consult launched Oncology OnTrack, web-based oncology navigation software designed to support the navigation of any patient. Kathy?
Thanks, Paul. Now that you've learned a little bit about mammography reporting systems and Priority Consult, let's talk just a little bit about how the two work together. How the systems, both of them, track the patient from screening to survivorship and any stop along the way. In this presentation, I will discuss steps 1 and 2 displayed here because, you know, this is definitely a journey for the patient. This is where the journey begins for our patient with her annual screening mammogram. Now our patient, Mrs. East, has gotten her letter that tells her exactly what to do. It's time for her to return for her annual screening mammogram. This letter was generated based on her mammogram that was performed a little over a year ago. Of course, our patient is compliant. She immediately schedules and calls and schedules her appointment. But if she had not, then we could send an additional recall letter from MRS if needed. This is the interface queue in MRS. This is where the patient and breast information sent from the radiology information system or the hospital information system lives in MRS, and the patient will appear here after her registration is complete or she has been arrived in the RES. This alerts the staff that the patient is ready for her imaging. Now our patient should appear on this list soon. Our patient has arrived for appointment. She is on time, and her name now appears on our interface queue. Is she ready to have her mammogram or her imaging? Well, not quite yet. What about her history? We know that the patient history is important and that we need to collect that, and it needs to be updated yearly. Well, with MRS Quest Touch, the patient herself can enter this information electronically, and it automatically goes into the MRS system. Or the facility may use a paper history sheet where information in this example is pre-populated, and all the patient needs to do is make corrections. But now there needs to be a manual transfer of this information from the history sheet into the MRS system, either by transcription, data entry maybe, or maybe even the technologist might be the person to transfer that information. Or the technologist might perform a personal interview with that patient and enter her history at the time of the interview. MRS offers the opportunity for extensive data collection about the patient. These are just a few examples of this data collection. But how does MRS use all of this information? Well, for over 20 years, MRS has been tracking, collecting, and reporting on this information. In 2008, risk assessment calculations were added to the software, and this information is also used in those. MRS also provides over 40 statistical reports right out of the box. Now the list here is a list of favorites, or maybe the most used. They can give you information on your patients. They can give you information on your staff. And they can assist, as the example here, this is the mammography audit, with your MQSA audit. They can also assist with credentialing for becoming a breast center of excellence. Now this is the demographic page in MRS. This lists the patient name, their date of birth, address, referring clinician. A lot of this information will come to MRS from your RIS or your HIS. There are also additional areas for data collection. For example, weight, blood pressure, ethnicity. If this is something your facility collects, you can put the information here. If not, then you can just leave that blank. Some of this information is used for the MRS EHR product. Now here is where the personal risk factors for the patient is collected. Here we see family history of cancer for the patient. You can see that we ask for the age that the cancer was diagnosed, but sometimes the patient won't know that. So we've also added the buttons, were they under 50 or over 50? We also collect maternal or paternal relation to the patient and many types of cancers. Genetic testing for family members is entered here. We collect the type of gene, the result, whether it was positive or negative, because it's important to know if that patient was tested, if they had a negative result, and if marker information is available, that information can also be entered here. This is the area where the gynecologic history for the patient is collected. As you can see, the terminology that you've seen on these slides are from the ACR BI-RADS lexicon. MRS is licensed by the ACR for use of the lexicon in our software, so we are required to use their terminology. Now here is where the hormone history is collected. As I said, MRS offers extensive collection of patient data. This is the procedure form. All the information that you see has been entered either by the patient or by the staff, and it displays here in a summary paragraph, plus any relevant prior procedure information is listed here. Now the technologist can review this history with her patient for accuracy, and at this point, if necessary, she can make changes. Once the technologist has completed the procedure and the images are ready for review by the radiologist could also use this information. He might look at this information to see if this patient has any history that would qualify her for any additional screening procedures. But MRS takes all this information one step further. Displayed at the bottom of the page is what MRS calls the risk dashboard. This is just another place that MRS uses all this data collected in the MRS system, and a risk calculation is performed on every patient without any staff intervention. Now the risk manager, the myriad prevalence table, and the GALE and NCI lifetime come standard with all MRS systems. MRS has a licensing agreement with Cancer Research UK for the use of the Taracusic or the IBIS risk model, so there is an additional licensing charge for Taracusic. I wanted to go into a little more detail on the risk dashboard. As you can see, this is a different patient. The risk manager picture is different, as are the calculations. As I stated before, MRS pioneered the use of risk assessment back in 2008 when we added risk assessment flags. We started with the GALE 5-year risk model. But soon we found out that was not enough. That was not what the clinics were asking for. So we have added the NCI lifetime or the modified GALE, the myriad prevalence tables for BRCA mutations, and Taracusic. Now the risk manager is based on the algorithms provided in the NCCN guidelines. The risk manager is a visual indication for increased surveillance for the patient. This might include a screening MRI, BRCA testing, or medical intervention options. Once again, I want to point out that no intervention by the staff has occurred, and that these risk assessments occur on every patient. Let's talk just a little bit about the options that the radiologist has to enter those findings into MRS. There's many ways. Of course, they can work off of a paper worksheet, and we know that they check boxes or they scribble some numbers or even they scribble some text, and then transcription has to decipher all of that information and get it into the system. They can also dictate to the transcriptionist, and once again, the transcriptionist must listen, decipher what they've said, and enter that information into the system. The radiologist can also do structured reporting or direct data entry into the system, and this is where they check all the little boxes. Sentences are generated. They finalize while they're looking at the report. MRS also has multiple integrations with voice recognition systems such as PowerScribe 360 and Dolby. This information populates the text as the radiologist dictates into the system. They can either finalize, make corrections and finalize the result while they are there, or they can save this for correction by a transcriptionist. And MRS also provides templates for use by the radiologist, either one-touch or what we call a template tree for more complicated cases. Now that the results are in the system, we're ready to send the report to the referring clinician, and we're ready to send the patient her letter. And we know that the letter and the report to the clinician are required by MQSA. You know, this might be the end of the journey for a patient that's negative or benign. But what if our patient has a high-risk score? Maybe she's negative with a high-risk score. Or what if she lives in one of the states that has the breast density notification laws? If you will notice in the example, there's a couple of red boxes. MRS can populate either the breast density notification statements, or they can populate a paragraph about the patient's risk assessment. Depends on what the site prefers for the wording of these paragraphs or what the state law is. This letter is highly customizable. And I want to point out again that this is an automatic insertion of these paragraphs without any intervention by the staff. Now let's talk a little bit about the patients that have a finding, either a BI-RADS 0, 4, or 5. Paul mentioned this a little earlier. You know that those patients can be need help, need follow-up by a navigator. Of course, we sent that patient her letter, told her what she needed to have done, and we gave her instructions. You know, here's where you call. Here's where you know what you do. This is your next step in your journey. Of course, our patient called and scheduled her appointment, but in case she didn't, at a site-defined set time, MRS can send her additional letters. Now she comes in, she has her images, and she's going to get results of those. What if this patient needs to have a biopsy as a result of her ultrasound that she had performed? Or what if the radiologist has recommended genetic testing based on her risk score? What if she needs to have a screening MRI? Or what if that biopsy was positive? Who will help the patient through the next steps in her journey? How can all of this information be used? This is where the navigator may come into play. Even if your facility does not follow the patient through her cancer treatment, someone needs to assist the patient with her next steps, maybe for her biopsy, or assist with scheduling that MRI. We know how difficult sometimes that can be. Or maybe we need to help her find a genetic counselor to go over results of her BRCA testing. Maybe the navigator is going to be the person that's going to review that information with the patient. MRS can transfer all of this information to OnTrack navigation. There are no faxes to remember to send. There are no phone calls to have to remember to make. And there are no lost Post-it notes. And we all know that the navigator's busy, and when we stick that on our monitor, sometimes it gets lost and put in the trash. Paul, will you now take us through the next steps of the journey, showing us how navigation can be used to assist the patient and the staff on this journey?
Sure. Thanks, Kathy. And for a navigator, imagine all that upfront work that Kathy was talking about, automatically populating a software tool that they use to manage their everyday work so they can see all the significant breast cases that they need to work on that particular day. That's what we were talking about earlier with the unfair advantage for a navigator. With the data transfer, let's look at exactly what comes over from the MRS application to Priority Consult. This table summarizes top-level detail, what we do have coming over. Obviously, demographics, who the patient is, where they live, the procedure type that's being done, whether it's imaging or a core biopsy, detail on that procedure, where it was done, which one of your facilities, when it was done. If it's imaging, what's the overall assessment or BI-RADS score? Pathology from biopsies, whether benign, high risk, or malignant. And of course, the recommendation and next step from that procedure. All extremely valuable information for that patient navigator. And how does that information get to you? The information comes over through an interface from your MRS server to the Priority Consult application, obviously through an encrypted data transfer. We won't spend much time on this, but this basic schematic shows you how information does flow from the MRS application to Priority Consult. So great navigation starts with a great screening and diagnostic program. So don't get the cart before the horse in this situation. We see a few navigation programs who don't have much of a connection to their screening and diagnostic program. All that important upfront work needs to be communicated in an effective manner to the navigator. The MRS Priority Consult interface makes that extremely easy. And for your program and defining navigation, whether you have an existing navigation program or you're creating one, if you Google it, you'll get over 7 million results. Lots of information out there. Really, what it comes down to for Priority Consult is focusing on Dr. Freeman's 3 basic principles of navigation that he focused on when creating the first established navigation program. Identifying and removing barriers of care, improving access to care, and increasing the patient's understanding of their situation. Really, those 3 things still hold as fundamental truths for the Priority Consult program and how we support navigators in tracking patients. So look at your program. What are the features and benefits of the navigation that you offer? Maybe you focus on a certain aspect of tracking. How does that benefit the patient? So what we've got here are features and benefits of the OnTrack application, but this information can be applied to exactly what you do at your center, creating treatment summary documents and survivorship plans. How does that help the patient? How does that help your center? So listing out items that you consider features of your navigation center, and how does that benefit the program, the patient, and how can that be translated to specific navigator activities? That's what we've done when creating the OnTrack application. We all know that if a program doesn't contribute to the bottom line for a cancer center or for a hospital, it's hard to get through administration. And navigation is viewed by many as a cost center, not contributing to the bottom line. However, it's simply not the case. It's easy to say and hard to prove. Navigation is not a cost center. Let's take a look at a business case for navigation for some real Priority Consult data from some of Priority Consult's largest oncology clients. What we have here is a measure in reduction from year 1 to year 2 in patients seeking treatment elsewhere, patients declining treatment, and appointment no-show. Now, this was year 1 and year 2 of actually using the Priority Consult application. It would have been even better results had we been able to get data before the use of Priority Consult. It's hard to come by. So we focus on the next best thing. An 18% reduction in patients seeking treatment elsewhere. And that can be directly attributed to the patient navigator creating a relationship with their patient. That upfront bonding and rapport goes a long way when the patient's choosing where they're going to receive their treatment, whether it's with your hospital or the hospital 45 minutes away. Patients declining treatment. That comes into the education standpoint, patients understanding their situation. A 6% decline in patients choosing not to have treatment. An appointment no-show rate, a decline of 39%. So imagine translating those percentages to dollars and cents for your program. I think that would pay for your navigation program and then some. Also, the navigators were able to increase their workload by almost 10%. And being able to reduce wait times by 18% from abnormal imaging to biopsy and biopsy to primary surgery. So that patient navigator acting as a bird dog, helping to identify barriers to care, seek them out, and break them down to make sure that patients are getting from A to B to C as quickly as possible. So let's go back to the navigation data path, where Kathy focused on items 1 and 2, annual screening and diagnostic workup. That handshake between MRS and Priority Consult really happens at stage 3, in between stage 2 and stage 3, where we've got possibly diagnosed patients, where we've got all their good screening and diagnostic information coming over from MRS, so a breast navigator can help prepare that patient for tumor board or breast case conference. The critical steps in navigation, things that we focus on with our clients, making sure that new navigators or existing navigation programs don't get overwhelmed in the amount of work that they're trying to do. We try to focus on some key steps. Patient intake, where to begin, barriers to care and stress assessment, making sure that we focus on that at the beginning, tracking that patient through interdisciplinary review or conference, making sure that treatment decision gets made quickly and gets documented, and then navigating that patient through treatment, whether it's surgery, medical oncology, radiation oncology, or a combination of the three. And then once that patient's acute treatment is over, ensuring that that navigator has a sure, tested way to track that patient into survivorship, and that the survivorship queuing function allows you to track that patient for as long as you'd like, whether it's 5 years out or even longer. Critical step in navigation, we're going to focus here on intake. What we have here is a sample navigator daily snapshot produced by the OnTrack application. We're logged in as the navigator, Paul Pugsley. And what we can see here are 3 items that I need to take care of today. I've got a procedure report, another procedure report, and an appointment record to take care of. So what this does is defining where you want to start tracking patients, whether it's the point of diagnosis or earlier, at the point of an abnormal screening. You can see here in these notes that this navigator has set up the fact that she needs to make sure that the PCP gets the mammogram report as he referred the patient with a powerful lump. After that intake has been established, we need to make sure to complete a barriers to care and distress assessment. Here we've got a couple sample screenshots on tracking that patient into that distress assessment form. Being able to track when the data is collected, how it's collected, overall distress level is crucial for a good distress form. In this sample navigator daily snapshot, we see that our patient needs to have that distress form completed today. Barriers to care and distress assessment. The barriers to care goes along hand in hand with collecting distress data. So within this distress assessment, we want to make sure that we hit on what might be some stumbling blocks that the patient encounters: child care, housing, insurance or financial issues, transportation. Being able to collect that data with the patient in front of you or over the phone, and then reviewing it in real time or after the fact with the patient to make sure that we get their barriers identified and taken care of. The next major function that we want to make sure to support is interdisciplinary case conference, or tumor board. Here in our Navigator Daily Snapshot, we have a patient who's going to be presented in conference. And this navigator uses this on her work list to make sure that she gets everything prepared for that case conference presentation. The navigator can also document final treatment decision, so she makes sure to have everything outlined in her software tool so she knows what the next steps are for the patient, make sure that they get taken care of. After tumor board, the treatment decision process, the navigator wants to make sure that all the consultations get set up that need to be taken care of. For example, a surgical consult, medical oncology consult, and pre-surgery education. The navigator can use the application to set follow-up tasks according to what she thinks or what needs to be taken care of next. And these reminders will pop up in her queue so that she can work on them in time order. Treatment navigation is really the critical part of tracking. This is where we get all the good information about the patient's treatment so that an accurate treatment summary document can be created at the end of the day for survivorship planning purposes. Here in this particular daily snapshot, we see a surgery record that the navigator needs to take care of, whether it's calling the patient prior to her surgery or going to see her after the surgery is done at her bedside. Follow-up reminders are critical for a navigator to make sure she stays on track. In the survivorship phase, after acute treatment is over, we've developed a flexible survivorship form to make sure that all tracking can be taken care of according to your COC requirements on what a survivorship plan includes. Whether that's identifying medical and history physical follow-up for the next 5 years, other referrals, or anything else that a navigator needs to take care of or a patient needs to be aware of for her survivorship care. To summarize the data path, we've now reviewed the additional steps 3, 4, and 5 on how to follow a patient through the continuum of care and how the data from MRS helps support that data tracking. After we've done all that acute tracking up front, the information can be used to help with accreditation reporting. It can be a mess, so let MRS and Priority Consult help clean it up for you. With information gathered, we have the ability to report on all indicators that you need for NAPBC and QMBC reporting. Here's just a sample summary of that information. We have a slightly different philosophy that a navigator can work with some basic treatment information that can support your reporting at the end of the day, while we want to make sure it's kept to a minimum so the navigator can focus on patient care. We also have the ability to report on individual program status. For example, how many tasks is a navigator completing per month or per week. And that's created through a navigator activity report where a navigator can log certain events they have with the patient or that they do for the patient. For example, education, phone calls out to referring physicians. The information can also have a timestamp on it so that you can report how much time a navigator is spending on a particular activity. An acuity manager allows a navigator to indicate how much time it's taking to work with that patient, how much effort that patient is taking. We can look at that on a program as a whole if you have more than one navigator, make sure that no one person is stuck with the most demanding patients. And while it's kind of a subjective indicator, it's still beneficial to review. Tying in your team is crucial as well. A navigator needs to make sure that she knows exactly what's happening with every single patient. However, she might not need to take care of all of those tasks. The Priority Consult application allows the navigator to create certain follow-up items for other people working within your program. In this example, we have a support service, transportation, where a navigator discovered that the patient doesn't have a car on Tuesday through Wednesday and that transportation needs to be offered for this patient. So the navigator is creating a task to go to a support services team to notify them that they need to contact this patient. Also, tying in clinical trials folks can be helpful. For example, making sure that that patient does in fact get screened for clinical trials, and do they ultimately enroll in one. The side effects of good navigation is good data at the end of the day to support your reports. We went over this a minute ago, and we just want to rehash that the navigator can help. Interfacing is key, navigators are key, and software is essential to make sure that your process gets tracked effectively and that at the end of the day you have good reportable data. Mike, you want to take over about the...
Absolutely, Paul. Thank you so much, guys. This was extremely helpful. For those of you who are planning to attend the NCVC conference in just a couple of weeks, I want to let you know that the integration doesn't stop at the software. The two booths for MRS and Priority Consult will be sitting right next to each other. You'll have an opportunity to speak to both Paul and Kathy, as well as their colleagues, to learn more about these products. And if you have further questions or comments related to this integration or either system, feel free to call Oncology OnTrack. The folks at Priority Consult are happy to speak with you at the information as you see in front of you. And as well, you can reach the folks at MRS at sales@mrsys.com and send them an email, and they'll be happy to follow up with you. I want to thank you all for attending our webinar today and look forward to seeing you at our next meeting. Thank you very much and have a great day.